Hello, and welcome to today's HEAL Headliners webinar. My name is Carol Giannessi, and I'm an American Association for the Advancement of Science and Technology Policy Fellow with the HEAL Office, and I've had the pleasure of working with the two HEAL grantees who are presenting today. The chat feature is not being used for today's session. To provide comments or questions, please open the Q&A, which is located towards the bottom of your screen. If you need to, please type the issue into the Q&A on to you. Finally, please be aware that today's session is being recorded. Close caption by clicking the CC icon at the bottom of your screen. It is now my pleasure to turn it over to today's moderator, Dr. Jennifer Humensky, Chief of Financing and Managed Care Research Program at the National Institute of Mental Health, Division of Services and Intervention Research.
Good afternoon, and thank you for joining us today for this HEAL Headliners webinar. As Carol mentioned, I'm Jennifer Humensky, and I'm the Chief of the Financing and Managed Care Research Program at the National Institute of Mental Health, Division of Services and Intervention Research. Today's webinar will highlight the work of two HEAL-funded researchers who are examining risk and protective factors for opioid use disorder and pain. Their research has real-world implications for two specific populations: youth experiencing homelessness and pregnant and postpartum individuals. Our first speaker is Dr. Natasha Slesnik. Dr. Slesnik is Professor of Human Development and Family Science in the Department of Human Sciences and Associate Dean for Research and Administration at the College of Education and Human Ecology at The Ohio State University. She's a licensed clinical psychologist whose research focuses on intervention development and evaluation with substance-using youth experiencing homelessness and substance-using mothers and their children. After opening a drop-in center for youth experiencing homelessness in Albuquerque, New Mexico, she moved to Columbus, Ohio, and opened her second drop-in center. So I will turn it over to Dr. Slesnik.
All right. So I'm excited to be here today. Thank you, everyone, for coming this Friday afternoon. I'm always grateful for the opportunity to talk about the work that we've been doing with these youth who have been experiencing homelessness between the ages of 18 and 24 years old. So this project that I'm going to be talking about today is part of the Preventing Opioid Use Disorder in Older Adolescents and Young Adults. So our focus is on these emerging adults, and it's a two-phase study that I'm going to be sharing with you. The first phase is a pilot feasibility study where we're testing an intervention that includes housing and risk prevention services for youth, and we're looking at that as compared to the same intervention without housing. So we're looking at the unique impact of housing on preventing opioid use disorder. I want to acknowledge my fabulous team with whom without these guys, none of this could be done. My MPI, Dr. Kelly Kelleher, he's a pediatrician at Nationwide Children's Hospital. And you see the co-investigators are, it's a true multidisciplinary team. We need all this expertise to be able to really effectively intervene with these youth who have multiple domains of struggle. So, why are we focused on youth experiencing homelessness? You might be surprised to hear that actually we believe that the opioid epidemic has disproportionately affected these youth. Samples from across the country indicate that 79% of these youth report opioid use, including injection heroin use, with over 50% reporting having had a drug overdose. So these youth are just at extremely high risk for opioid use disorder. Now, some people think, oh, but these youth, there's just not that many of them. Why focus on such a small portion of the population? Well, actually, 10% of emerging adults between 18 and 25 years old will experience a homeless episode at least once. So estimates are, they're not precise because it's hard to count these youth, but 3 to 5 million youth are experiencing homelessness every year in the United States. The problem is not a lot of people have been identifying and testing interventions for these youth, so we don't have replicable evidence-based preventive interventions that comprehensively addresses all of these youth's needs. Another issue is that while shelters are the front door for many people experiencing homelessness, it tends to be the first contact to engage in a range of services. Most of these youth don't access shelters. In fact, studies report that only a third of youth up to the age of 24 have ever accessed a shelter, even one time. Oh, there we go. So part of the problem for us is we need to find these kids and we need to bring services to them. These kids don't, if they're not going to the shelters, they're also not going to other services programs. Many of them are just, they're hiding on the streets. And when you're living on the streets, you're in close proximity to predators, you have easy access to drugs, you're fighting for your survival, where you're going to eat, where you're going to sleep, and how to keep yourself safe. So our thinking is that in order to truly prevent opioid use and other associated problems that these youth experience while living on the streets, we need to get them off the streets. So this is a justification for testing a housing intervention. Now, housing first is a name given to our philosophical approach that housing is a basic human right. If we provide housing before or at the same time as other interventions, it's more likely that the youth will benefit from those interventions and that they'll be effective. So this is different from traditional housing services where adults or youth will need to access a shelter, and at the shelter, they need to go through multiple steps in order to be eligible for housing. So they have to show that they're receiving treatment or that they're not using alcohol or drugs and that they have pay stubs. However, since our youth aren't going to the shelters and they're avoiding services to help them get off of drugs, this is an unviable way of providing housing services. Also, preventive services typically are offered in the home and school settings, or many of them are, not all of them, but this leaves out our youth. We know that housing, I mean, we have some indication that housing is important for people living on the streets for preventing drug use. And this study found that the odds of recent hard drug use for HIV positive adults experiencing homelessness were 4 times higher when they remained housing. And people who obtained housing were half as likely to use hard drugs and needles, to share needles, and to engage in unprotected sex. So housing is likely a powerful tool in the prevention arsenal. Now, some of the issues with youth specifically is I mentioned that services are available, but many of youth won't access those services, either because they can't, they don't have transportation or insurance, or they've had negative experiences in the system, either feeling betrayed by adults and its representatives, overwhelmed with the administrative burdens. So no matter how good the intervention is that we're using, it's not going to matter if we don't find the kids who need our interventions the most, and those are the ones really who aren't accessing any services. So we, in our project, we go out there and we find kids, we engage them in our intervention, even though they may not initially be motivated to receive our intervention, and we work with them for a period of time as they develop trust and openness to our intervention and other interventions as well. So what we use is this program. It's called the Strengths-Based Outreach and Advocacy. We use paraprofessional staff. They go to the streets and they find the kids. And we also go to a drop-in center and we engage them using strengths-based philosophy. And we give the youth the power to decide what they want to focus on. And this may sound obvious, but it's easier said than done, because when youth are engaging in very high risk behaviors, some self-destructive behaviors, it's hard for their advocate not to push them to make change. But when we push them, they leave and disappear. So another intervention we use is motivational interviewing. So it's a brief intervention. It's Rosarian, client-centered, and it has a strong record of prevention alcohol and drug problems, and it has shown some impact in studies focused on runaway and homeless youth. So this is our intervention. We provide housing for 6 months. We provide the rent, utility assistance, and then we provide these other risk prevention services. 6 months of the strengths-based advocacy and outreach. We provide 2 MI and HIV sessions. And for youth who report that they have suicidal ideation, we also offer a suicide prevention intervention. Now, I'm going to be talking about our pilot study. And because for our phase 2 powered randomized trial, we're still collecting data. So I don't have outcome data to support, but I do have the pilot outcomes, which I'm going to share with you right now. So to be eligible, the youth had to be 18 to 24 years old, experiencing homelessness, and they had to fail to meet DSM criteria for opioid use disorder. This is what our sample of 21 youth look like. So you could see there's overrepresentation of sexual and gender minorities and of Black and African-American and multiracial youth. We have typically equal representation of male and female youth. We housed all these youths and they received all the risk prevention services, and we tracked them at baseline 3 and 6 months. We also did in-depth interviews with the landlords who are providing housing and with the youth. So this is what we found. Drug use, with primarily marijuana use, showed a 35% reduction in frequency of use. Now this is significant because housing first trials don't always show that substance use is reduced with housing. But one of the concerns in the communities is that when you house youth, their drug use will increase. So we didn't find that. We also found statistical significance, even with this small sample size, in drug use consequences, in reduced drug use consequences. And the network affiliations changed. Youth reported smaller network sizes, but more friends with that were non-drug using. So they're changing their support network to non-drug using peers and less contact with drug using family members. They also showed less cognitive distortions. Our primary outcome, we found no youth began opioid use during the project, during this phase of the project. And also youth received a high number of sessions. So to our knowledge, this is the first study to engage youth at risk of experiencing opioid use disorder into a holistic opioid prevention program. So we believe this provides a foundation to continuing to work to prevent opioid use with this high-risk group for whom drug overdose and OUD is very high. And also, it confirms the viability of identifying at-risk youth who aren't engaged in services through drop-in centers, the streets, and engaging them in multi-session interventions. Some of the concerns are if we're working with people whose phones are, half the time their phones don't work, they don't have an address to find them, how are we going to engage them in multiple sessions of intervention? Well, we did it. So the youth were very engaged, and even during the epidemic, when we met less in person and tried to meet more over texting and FaceTiming, the kids were still engaging with us. And the kids didn't like HIV sessions, so when we delivered it, we'd say, "Oh, it's your HIV prevention session." So the kids often avoided us for those sessions. So we started integrating the content. This is a lesson learned into phase 2. We started integrating condom use and practice into just the regular advocacy sessions by getting the youth more interested in doing it in an interactive, fun way. So landlord experiences were positive as well as the youth. Now, what was interesting with the youth experiences is that they commented much less on the specifics of the interventions, and they focused pretty much fully on the relationship with the advocate. We did experience housing barriers, trying to get these kids housed when they have criminal records, when they have histories of eviction, bad credit, no credit. There's significant unmet service systems during the pandemic. For example, the Bureau of Motor Vehicles closed and we couldn't get kids' IDs, and that's what every kid needs in order to get housed and to get a job. They need you. You'd be amazed at how essential that ID is for just about everything we do. Okay, so this is our current project that we are now collecting data on. We're recruiting 240 youth and assigning half to the housing intervention with risk prevention services and the other half to just risk prevention services. And we're tracking them for a year. What I do have is some information about who these kids are. So again, we're seeing overrepresentation of Black multiracial youth and GLBTQ youth. You can see here that our youth are at high risk for suicide. Over a third of our youth reported having a history of attempting suicide, placing themselves in life-threatening situations, with 5 suicide attempts for those who had attempted at least once in their lifetime. While kids couldn't have opioid use disorder, many of the youth had tried it. And within the last 3 months, we had 10 youth. They're still using substances rather frequently. In this sample is primarily marijuana and alcohol. And also, while this was the longest day of homelessness, the average length of homelessness was about a year. So this is a pretty chronically homeless sample of youth. And then you can see here some of their victimization experiences. This is, again, I'm just showing you who these kids are. 95% of the kids reported childhood abuse experiences. So they're leaving home, they're going to the streets, and then they're getting abused on the streets, victimized. And then even their love partner relationships are not safe with them. So even though these youth are at perhaps the highest risk for opioid use disorder and overdose death, it may be considered difficult to engage. We find that they can be engaged in multi-session interventions. The relationship with the advocate appeared essential to the uptake of our intervention, and also to engagement with community-based services. The advocates were accompanying them most times to their appointments. We believe that the kids need more than just housing. They need housing and all of these supports around them. And we need to go out and find them. If we wait in our offices, these kids who we believe are in most need of assistance and intervention won't show up to the offices. And then we have there's some of these barriers to housing. So working with the landlords and negotiating with the landlords helped a lot, especially during the pandemic, because not all of our kids had IDs because we couldn't get them from the BMV. And so we had landlords willing to not require that. So finally, recommendations. So many of our youth also have been in foster care or in juvenile justice facilities. Half in foster care, maybe 2/3 had been involved in juvenile justice or adult justice system. Transitioning these kids into housing situations sure would prevent a lot of drug use and suicide, save a lot of money if these kids just never went to the streets. This is one of our recommendations. We also believe we need greater funding allocations to drop-in centers and for opioid and other risk prevention services. Most federal funding overall goes to the shelters and less to outreach and drop-in centers. Our kids don't go to the shelters. In terms of housing first, You know, if we find that housing is a powerful opioid prevention tool, then it follows that perhaps housing for those experiencing homelessness, maybe not just even youth, but adults, should be made a top priority in all drug prevention interventions. Housing should perhaps follow the philosophy of housing first, getting people off of the streets while you're intervening, even before you're intervening, not housing forth after they will fail. Sometimes the most chronically homeless adults or in adolescents are the ones who are less likely to succeed in meeting all the requirements of the continuum of cares that don't follow housing first. And to make things easier on those who come after us, changing the rules on who's eligible for housing and dealing with prior utility bills would be super important. All right, and that's my talk. Thank you.
Thank you, Dr. Slosnick. Our second speaker is Dr. Karen Zivin. Dr. Zivin is the Marcia Wallenstein Collegiate Professor of Psychiatry, Professor of Obstetrics and Gynecology, and Professor of Health Management and Policy at the University of Michigan. She's a research career scientist at the Department of Veterans Affairs and senior health researcher at Mathematica. Her research uses social science and public health tools to improve health and functional outcomes for populations at increased risk for substance use or mental health disorders, including pregnant and postpartum women. So I will turn it over to Dr. Zivin.
Hey, can everyone see me and hear me? I'm trying to make sure that you can see my slides. I'd like to thank you for the opportunity to present our work today, and for those of you who are here on a Friday afternoon. I would like to take a step back from the previous presentation and discuss work that my collaborators and I conducted at the population level among pregnant and postpartum individuals. First, I'd like to share more about our team and our research program. So my group, which includes clinicians, researchers, statisticians, data analysts, and project management staff, have come together under the Perinatal Mental Health Services and Policy Program that spans the departments of psychiatry and obstetrics and gynecology at the University of Michigan. We examine the impacts of health policies on functional and economic outcomes for pregnant and postpartum individuals with mental health and substance use disorders, including maternal morbidity and mortality. In addition, our work examines the impacts of maternal health on infant outcomes. So this forest of work, first funded by NIMH, began with a study that we call MAPLE, which assesses the impact of mental health parity and the Affordable Care Act on utilization and costs associated with mental health services among privately insured pregnant and postpartum individuals. From that parent award, we applied for 2 supplements. The HEAL Award extended this work in the same population to examine substance use disorders and added the impacts of perinatal substance use on infant outcomes, such as healthcare utilization. We call this the Birch study. I will focus on that study today. However, for context, I wanted to mention that we also applied for a smaller supplement to assess the impact of the same health policy coverage changes on maternal morbidity, which we called POPLAR. Finally, in a newer project, we included data from Medicaid as well as publicly available community data sources to assess how state policies affected perinatal outcomes. In that study called Spruce, we wanted to know more about the influence of community relative to individual factors on outcomes. So this study, funded from the National Institute on Minority Health and Health Disparities, will also include an expert panel and engagement directly with state policymakers. We plan to have our first panel meeting this fall. With that as background, I will now drill down farther on the Birch study. We wanted to look at policy impacts on pregnant and postpartum individuals and their infants, such as costs and utilization. In line with the notice of special interest for this HEAL mechanism, We looked at co-occurring trends and suicide risk among individuals affected by the opioid crisis. I alluded to federal health policy changes earlier, so I wanted to provide a bit more context. When I mention mental health parity, I am referring to the Mental Health Parity and Addiction Equity Act of 2008 that became implemented in 2010. For health plans that offered any type of mental health benefits, they needed to apply the same rules to behavioral health, so mental health and substance use coverage, as for medical and surgical benefits. Although a step in the right direction from prior policy, MHPA-EA does not require mental health coverage, and many loopholes persisted. When the Patient Protection and Affordable Care Act, or ACA, passed in 2010 and became implemented in 2014, it filled in some gaps for mental health parity, with coverage for 10 essential benefits, including mental health care and prescription drugs. Relevant also to our population of interest, maternity and newborn benefits also fell under these essential benefits. Returning to our study, we sought to assess the impact of behavioral health policy changes on opioid prescriptions, diagnosed disorders, treatments, and medications for opioid use disorders, or MOUD. We plan to examine suicidality, meaning suicidal ideation and self-harm, among mothers, and infant outcomes such as neonatal intensive care unit stays, adverse birth outcomes, and preterm birth. Finally, we plan to look at the impact of these policy changes on overall healthcare utilization and expenditures. We use data from a large private insurance data source across all 50 states and created a patient-level cohort of individuals with continuous enrollment in a single health plan for a year before and a year after the date of delivery. We are conducting a variety of statistical models to address our research questions of interest. Despite some of our preliminary work, we came to realize that we had relatively small numbers for some of our groups of interest. From a public health perspective, that is good, in that we did not have a substantial proportion of individuals with opioid use disorders and associated treatment, even if we technically had the statistical power to conduct a variety of analyses. As you can see, less than 1% of our sample had a diagnosed opioid use disorder, and less than 7% had substance use disorders. However, we did note a large increase from our initial study period between 2008 and 2020. So in the short term, we decided that we would first tackle another topic area of interest as part of this HEAL supplement. My collaborator in OBGYN brought in a colleague with expertise in complex gynecologic disorders and associated pain. For this analysis, we wanted to address several questions. We aimed to understand how chronic pain coexists with perinatal depression and anxiety, which, as you recall, was the focus of our original parent grant. We sought to look at pain over time among individuals with and without perinatal depression and anxiety, and learn more about the pain experiences of these individuals. For comparison purposes, we also included a similarly aged group who did not deliver a baby during the same study time period. Our analytic team developed yearly cohorts, and this slide shows an example of the most recent year of data we used, which was 2021. We started with all the individuals in our data source, then restricted to those women with a year of coverage among those considered of reproductive age according to the CDC definition, and then included those who had at least one delivery and evidence of health services use in the year prior to delivery. We used a comparison group that did not deliver during that same year. This and the next few slides present our results. I note here that this paper is available now online in proof form and will be available through open access from the journal in its final form. Individuals with depression and anxiety had twice the probability of experiencing chronic pain compared to those without depression and anxiety. I will show this finding in a few ways. We learned that half of the delivering population with anxiety or depression had chronic pain. Pain is quite common among those with anxiety and depression. We also looked at a variety of types of pain and found the leading conditions included pelvic and musculoskeletal pain. This slide shows another series of comparisons. We compared delivering people to non-delivering people who did not have anxiety or depression. So those are the blue versus green comparisons. We repeated the same analyses among those with anxiety or depression, which are the yellow versus purple comparisons. Again, we also show that pelvic and musculoskeletal pain were the top two types of pain that occurred most often in delivering people. This slide provides another way of seeing the comparison between delivering people with and without anxiety and depression. We found a consistently higher prevalence of pain in those with mental health conditions and a decline over time, but still high prevalence. I now present the key takeaways from this work. We saw significant overlap or coexistence of the mental health conditions and chronic pain, pointing to a substantial unmet need and opportunity to improve clinical care. If we want to address behavioral health conditions, including mental health and substance use, as well as maternal morbidity and mortality, including suicide, we need to target this population. This may involve focused programs or approaches that include care coordination for pregnant and postpartum individuals managing chronic pain. I wanted to mention some additional future directions as this work represents early findings in our overall body of work. We will dive deeper into the pain conditions and treatment by key demographic subgroups. We have work underway that addresses infant outcomes among individuals dealing with chronic pain. We are also looking specifically at healthcare utilization and costs among mothers with behavioral health conditions and their impact on infants, so the maternal-child dyad. Finally, as part of the Spruce project I mentioned earlier, we will have a chance to replicate this work with mothers in a Medicaid population, which has a higher prevalence of substance use disorders and opioid use disorders. So I also wanted to recognize my collaborators and team and wrap up so that we have time for questions. I also wanted to acknowledge our NIH funding for this research. If you'd like to see more information about our studies, you can follow this link or QR code. So thank you again for attending today and for your interest in our work, and I will be happy to answer questions.
Thank you very much, doctors, both of our presenters, Dr. Slesnik and Dr. Zivin, for presenting this research and for showing how interdisciplinary interventions can help to improve health and address opioid use. We do have a bit of time for Q&A, so we welcome questions. Please feel free to put them into the chat. And I'll start with the first question. This is for both of you. How has engagement with people with lived experience benefited your research?
I can go. So we have a community advisory board, and our board always includes youth with lived experience who are currently, some have history, but currently we have someone on this board who was essential for directing some of the directions we went in service provision, because they are currently in the midst of their crisis and warned us about the ways we interacted and dealt with other services that we were coordinating with and the way we provide services, how housing would go. I would say it's essential to success.
So as I mentioned, our study is obviously at a different level where we're using, administrative data, and it doesn't specifically include individuals with lived experience. I could say that I am personally someone with lived experience with the condition that I studied, but also we have informally connected with people with that type of experience in a wide range of, mental health, substance use, chronic pain conditions. But this study, again, focuses at the population level using a variety of existing data sources and does not specifically focus on either community engagement or qualitative data.
I have another question. This is also for both of you. What are some lessons learned that you would share with other studies planning to engage people with lived experience?
Well, for working with youth experiencing homelessness, I would say try to engage more than one youth in your activities, because you'll get all sorts of different ideas from different perspectives and at the time that they've been experiencing homelessness. So those who are currently homeless, those who might have been homeless in the near past. Because sometimes too, you get youth on your in your groups that they're not very talkative. And so if you only have one and they're quiet, you know, it's hard to drag the words out. So I think it's important we learned not just to have one.
I think that it's important to understand individuals' potential gaps in care, as well as challenges with care coordination, especially among those with complex health conditions. So if they're dealing with mental health or substance use conditions, as well as pain, and they're dealing with a pregnancy or newly postpartum, they may also be involved with primary care or pediatrics. There are a lot of different opportunities for care, but there's also a number of opportunities for gaps or falling through the cracks, or providers not being in sync with one another. That can be challenging for patients to deal with. And so I think that trying to understand what is working for individuals and also where they are struggling or not having their needs met can inform higher quality care.
So I have another question for Dr. Slesnik. What do you think it was about the HIV session that led to lower attendance?
I think that for the youth, there's so many other issues that they want help with. And so when we separated the HIV sessions into their separate meetings to focus on that, the youth instead wanted to focus on things, I think, that they felt were more important to them. And we have done other qualitative interviews with youth who don't recognize the risk that they're experiencing every day, not using condoms. So we started integrating it with content that they did want to receive. And when we could meld it together, they were more open to it than when we separated it, being something that I think they didn't recognize as important.
Thank you. We have another question for Dr. Slesnik. Probably the abusive backgrounds, about 95% of youth, largely occurred while housed. How did you design and control the 6 months of housing to stem for any further abusive social contacts and family?
Well, we used a housing first philosophy, so we didn't manage people that were allowed in the home or who you could see. Now, we only created leases for the youth to sign, so we didn't allow the youth to sign leases with other people for the 6 months that the project was paying the rent. But we did not prevent youth from seeing, we couldn't prevent them from seeing people. So there weren't very many. You asked about controls, right? We didn't have controls against who they saw. But oftentimes, if youth had a violent experience or if they suffered some victimization, they call their advocate. So the advocates were often their first call for help when things happen.
Thank you. We have a question for Dr. Zivin. What type of interventions do you think could be effective to address both pain and mental illness in the population that you've studied, given that right now you have administrative data?
Right, that was what I was trying to talk about with respect to, I guess it would be collaborative care, not just care coordination, but ensuring that people have care plans and processes that account for their multiple conditions with the relevant providers who are all on board and trying to work in the same direction in terms of whether these are therapy-based options, whether they're physical therapy, or other types of medications that may or may not be appropriate, but both during pregnancy and afterward. I think that making sure that people have providers that are skilled and aware of the complexity of these types of issues, as opposed to potentially just purely in one field or another. So I think that's my sense. I admit that I'm neither a clinician nor an intervention researcher, but that would be my suggestion.
Thank you. Another one for Dr. Slesnik. It sounds like the relationship with the advocates is an essential mechanism for the success of your intervention. How do you ensure a good relationship with the youth? What training is involved for the advocates?
So we have the advocates shadow other advocates at the beginning. And also the selection process of advocates has evolved over the years. Advocates have to be super comfortable in non-traditional situations, and the ones that have been successful, sometimes they've had lived experience themselves. I'd say maybe half our advocates have similar experiences to the youth that we're trying to serve. So there's less fear. There's of going into going to find the youth wherever they may be, because we go out and find our youth. They're not coming to us. So they get training through manuals and didactics, but then most, I'd say, the training is in vivo. It's shadowing, and then it's taking over the lead, and then having a more experienced advocate with them to guide them until they're ready to be on their own.
Thank you. I have another question for Dr. Slesnik. Can you tell us more about how the data are collected, particularly the substance use data? What measures are you using?
We use the 490.
Okay.
Yeah.
Thanks. So question for both of you. How did the COVID-19 pandemic and related public health emergency affect the populations that you studied? And how did your research adjust to meet these challenges?
Do you want to go first, Dr. Zivin? All right. Well, so our youth couldn't shelter in place. So when everyone was locked down, our youth weren't able to lock down. And when our kids would get COVID, it was, terrifying for them. But the other issues that we dealt with were also getting staff willing to, so we continued to meet with youth in person. This is a life-death crisis situation, getting these kids medical care and getting them essential services. So we had a lot of staff turnover, which was a challenge. We had troubles getting them the services because some of the, like I mentioned, the BMV, but there were other services that became very difficult to access during the pandemic. Yeah, it was kind of it was a nightmare.
For this work, which I saw there was also a question about private versus other forms of insurance. And right now we're just looking at this population that I talked about today was private insurance. We've looked also, we're starting to look at Medicaid separately, but with the data lags, we're just now seeing some of the effects of the pandemic period because, having 2020, 2021 data, I think we are certainly seeing higher prevalence of, mental health and substance abuse conditions. And the population that we're dealing with was at substantial risk. Many individuals who are delivering have have other children. And, the pandemic obviously made it difficult for people who worked outside the home or returned home or their children came home. And so a lot of the challenges that some of these individuals faced were exacerbated certainly individuals with mental health conditions or other challenges during pregnancy had a lot of difficulty immediately during the pandemic because, for example, partners were not allowed to attend deliveries or any other people. So there was a lot of fear and uncertainty, as well as potential, exposure being in a hospital. So I think that we will continue to see more as we play out after the work from the pandemic. But I think, as we all know, it had a negative impact and health for pretty much everyone in different ways. So we will certainly be learning more about that.
We have another question for Dr. Selesnik. Could you speak to any differences between your work in New Mexico versus Ohio?
So I worked in New Mexico 22 years ago, so things might be different now. But when I moved to Ohio, there were no drop-in centers for youth experiencing homelessness. There was a shelter, which, like I mentioned, youth don't go to. So I would say that the services in Ohio were more difficult to coordinate for these youth, and to get the community around acknowledging that there were homeless youth that needed these services in Columbus. So when I moved here, that was the big difference, is the way the community considered youth homelessness. And at least in Columbus, they denied that these youth existed. Albuquerque, at the time that I was there, also the shelters and the drop-ins, they worked together, and there wasn't, so I'm speaking kind of as a community person right now. There wasn't a competition for money, for supports, for funding in Albuquerque, and so there was more collaboration amongst the service providers and for I would say like my program, the drop-in center. It's a very different experience. Now amongst the youth themselves, I'd say there's different demographic. In Albuquerque, we served maybe half of our youth were Hispanic, and we had Native American youth, whereas here in Ohio, we don't have too many Hispanics, and I don't think we have any Native youth in our projects. Maybe we've had a couple. Yeah.
I have another question for Dr. Zivan. The observation of higher prevalence of any SUD in 2020 compared to 2008, does this reflect higher SUD levels, or is this due to higher access to services through policy change?
It's complicated for multiple reasons. It could be higher prevalence of illness. It could be greater detection of illness. It could also be other things, such as the switch from ICD-9 to ICD-10 that also occurred during that same period between 2008 and 2020. So it's one of those areas that's a limitation of administrative data, that there can be multiple factors that influence an increasing prevalence. It could be a good thing that we're at least detecting more illness. You can't obviously know from this type of data what the true underlying prevalence of illness is. And so that's something that, we try to unpack, but also understand the limitations of the information that we have.
Another question for Dr. Selesnik. Are you seeing a lot of changes in the phase 2 study, given the prevalence of the especially deadly drug supply like fentanyl?
Yeah, 5 youth in our study of 240 youth have died, which is the highest I've ever experienced in my work with youth experiencing homelessness, and those are the ones that we know about. So 5 youth deaths. Now some of them were 3 of them were killed by gunshots, but the other 2, we do believe there's been fentanyl related deaths in the homeless youth population. Yeah, it's been it's gotten worse. I would say it's really bad over the pandemic. Our kids were at risk. There was a lot of it was the most suicide calls I've ever gotten, the most deaths I've ever gotten. And Now, we screened out kids who were at risk for, we screened out youth who had opioid use disorder. So most of the youth in our study were using just marijuana and alcohol. And we didn't see huge increases because I think they were receiving services in our study. But for the broader homeless youth population, yeah, I'm aware that there's been a lot more overdose deaths.
Well, it's a question for both of you. In general, and they spoke about, each of you spoke about the future directions for your work, but is there anything you sort of want the audience to take away in terms of future directions, or if there's one takeaway that you want the audience to take away from, what would that be?
I feel like I'm always going first. Do you want to go first? For me, I think was super important takeaway is when we're working with marginalized groups who are hiding on the streets, who've had bad experiences with substance use treatment programs and schools and juvenile justice, and they're just avoiding all the systems. We need to do things differently. We need to go out and find these people, and we need to pull them into services to get them to get them off the streets, to get them their goal, to help them meet their goals, and to start developing some hope and trust in these kids. Otherwise, we're just going to have so many deaths because our kids are dying. These kids are dying. We have to help them. And we can't wait in our offices. And I think most of us, we think about traditional services. We need to meet these kids where they're at.
Part of why I like to go after you is just to give myself a chance to think. But I guess stepping back from, the specific analysis I shared today, I'm really concerned about maternal morbidity and mortality. We see that those numbers are bad and are only getting worse, and there are huge disparities. And I'm very concerned that our statistics that we gather on this population does not typically even include mental health or substance use conditions, including suicide. And so if you're not documenting those individuals in national data, then we're underestimating the burden of the problem, and we're missing key people that are in greatest need. And so in a different way, I'm also concerned about the direction that we're going in and unmet needs, and trying to figure out why is it that the US has, the highest rate of maternal morbidity and mortality in the industrialized countries. And I think mental health and substance use, and also, co-occurring pain, like these are some of the highest risk among those who were already in high risk. And so really being mindful of understanding the circumstances that those individuals face, counting them and figuring out what we can do to decrease these outcomes.
Well, thank you both so much for sharing your work with us and providing this update on your findings. And I'll turn it over to Carol.
Thank you both so much for sharing your important work today. I hope you can join us for our next webinar on Friday, August 4th at 2 p.m. entitled Mapping the Path to Relief, Improving Pain and Opioid Use Disorder Through Neuromodulation. Thank you all.